Thanks, Dick, and welcome everyone to our little presentation here this afternoon. I have no particular conflicts here, and what we're going to talk about for the next few minutes is what's going on in is aware, I'm sure, impairment and apportionment are very important concepts, especially to the defense. The defense is always asking QMEs and AMEs what are the factors of impairment that are available for a particular individual, and what's the how and why of why you can do that. What actually in the literature supports this. So I'm going to spend a year. Obesity is associated with hypertension, diabetes, heart disease, some cancer. Hello, and thanks for listening to our discussion about apportionment and causation. As everybody's aware, apportionment and causation are important topics to AMEs and QMEs. The defense primarily is interested in establishing if there are other factors that can be used to apportion out certain levels of impairment in an individual. And what I'm going to try to do over the next few minutes is give you some understanding in the literature of the how and why of what supports apportionment in certain particular situations. I have no conflicts of interest associated with this talk. Just a little demographic background here. Low back pain is the second most common reason for primary care doctor visits. It's estimated to cost about $200 billion a year, so it's a big deal. Obesity is associated with hypertension, diabetes, heart disease, some cancers, osteoarthritis, and more clearly, low back pain. Obesity is a rampant plague in this country now, maybe not quite as big as the coronavirus at the moment, but it's really up there. BMI, obesity is defined by the WHO, that famous organization that the president is so fond of these days, as a BMI of 30 or more. Severe obesity is defined as 40 kilograms or more. Overweightness is defined as 25 to 29 kilograms, almost 30 kilograms. 42% of Americans are now obese. This is the most recent data. An additional 9% are severely obese. Ranked low to high, Asians, whites, Hispanics, and blacks make up that cohort of individuals who suffer from obesity. So you can see there's differences between different groups. This data comes, as you'll see at the bottom there, from a recent data brief that was sent out by the NCHC. Low back pain, Chow et al. Have shown that men with higher BMIs and waist-hip ratios are associated with high intensity, low back pain, and high disability. There is no evidence that lean body mass was associated with such problems. And you can see the data there, or the citation there that you can use if someone asks you how and why what you're talking about there. Shui and al. Showed that with meta-analyses, they found that overweightness as well as obesity increased the risk of low back pain. They also found that for those with moderately heavy or heavy work lifestyles, those changes actually reduce low back pain. So there's a conflict there that maybe you could choose one side or the other of, depending on the individual case you are evaluating. Defina et al. Did not find any significant difference between the impact of obesity and back pain. They quoted several other studies from earlier in this century which supported their conclusion. But more recent studies, as the epidemic of obesity spreads across the country and perhaps even the world, it's becoming clearer and clearer that low back pain is associated with obesity. Freilander et al. Did a longitudinal study and found that BMI among men at certain ages, at age 20, predicted low back pain later in life. Both general and abdominal obesity were associated with radiating low back pain. Cherie reported that the effects of leisure time activities on low back pain are still unclear. Previous observational studies reported inconsistent results, he concluded that obesity increased the risk of low back pain, but walking and cycling reduced that risk. Rofi pointed out that more studies have suggested associations between obesity and inflammation. These studies have focused on C-reactive protein, tumor necrosis factor, interleukin-6, and adiponectin. So it isn't totally body weight as much as fat mass that may be at play here. Dario studied twins and noted that while obese patients are twice as likely to have low back pain, the association diminishes when factoring genetic confounders. That suggests that weight loss may not be effective in treating some genetically compromised patients. Sheng et al. Found that disc disease and low back pain are linked with obesity and overweightness, but also weight predictions predicted low back pain disease, but not cervical disc disease, supporting the concept of mechanical rather than inflammatory damage. Romero Corral et al. Have shown that the accuracy of BMI in the intermediate range of body weight is limited because BMIs can't discriminate fat from lean mass, but BMIs over 30 have an excellent specificity for diagnosing obesity in both sexes. Gelber found studies which showed that higher BMIs and older age were associated with total hip replacements. We're moving on to the hips now. Women with the highest BMIs were twice as likely to get a total hip replacement than those with the lowest BMIs. He estimated that absent obesity, osteoarthritis would decrease by about 25%. So there is scientific literature to support the concept of apportioning hip disease and hip impairment to obesity. Schwartz et al. Reported that in their study, obesity had only a weak association with hip pain. Depression had a strong association with hip pain. So there's a conflict here, and in an individual case, one may need to decide and weigh the pros and cons before coming to a conclusion about how to apportion weight to hip arthritis to obesity. Tuxen wrote that hip pain increased with higher BMIs, whole body vibration, and heavy work. The literature also documented that a pound of weight loss resulted in 6 pounds less force on the hip joint. With regard to the knee, Messier reports that there is a significant direct association between BMI and peak compressive forces at the knee. Each pound lost results in a 4-pound reduction in knee joint load. So it's pretty clear and pretty well accepted that obesity is an important factor in creating damage to knees. DeFore reported that the recent studies confirm that obese patients are more likely to have pain than slim patients. 3 to 6 times body weight is transmitted to the foot and ankle during normal walking. The foot and ankle are another area that can be significantly affected by obesity. Butterworth, with regard to the foot and ankle, reports that general foot pain and plantar heel pain are strongly associated with increasing BMI. Obesity is strongly associated with pronated flat feet and increased plantar pressure when walking. Walsh et al. Reported that as body weight and plantar pressure increase, foot pain increases, and the midfoot may be the most vulnerable site for pressure-related pain. And that concludes my part of this presentation.